And now it's my pleasure to start the next session, which is the academic session. And I would like to introduce the chairs here. I can see the whole panel and team have already joined. That's a pleasure. First of all, I would like to introduce Miss Cynthia Bow. She's a close friend of ours, works in London. She's a bariatric consultant. She's quite active in academics. She's a council member of the BOMS. She's a council member of the OGIS, and she's a regional advisor to the Royal College of Surgeons of Edinburgh as well. So welcome, Cynthia, for this session. And second, I would like to introduce another colleague and friend of ours, N. Balaji. He's a bariatric consultant surgeon at Stoke-on-Trent, active in academics, special interest in GERD and esophageal diseases. He is again council member of BBUGS, which is part of OGIS. He is also leading in the National Hiatal Surgery Registry. So welcome, Balaji, as well. And now Cynthia and Balaji, the Zoom screen is all yours.
Thank you very much, Chetan. Thank you, Cynthia, for joining us together again. The academic session. There is a saying, the dumbest thing about mistakes is not learning from them. So the first topic in our academic session is making bariatric surgery safer, and this would be presented by Bridge Meadow on learning from mistakes. Bridge is a good friend and a colleague who's a consultant upper GI and bariatric surgeon at the Derby and Burton Hospitals NHS Trust. He is also a honorary assistant professor at the University of Nottingham School of Medicine, and he's a founder member of TUGS and has been actively involved in the coordination of the LIBSS as well. Thank you very much, Bridge, and over to you.
Thank you so much, Balaji and Cynthia, for the kind introduction. I would start with sharing my screen. I hope you can see that okay and hear me okay as well. Okay, so I would, at the start, I would say thank you to Kamal and Sanjay for offering me to talk on this interesting topic. So as rightly introduced by Balaji, I think we all will agree from primary school, we are taught that you will make mistakes, but important thing is to learn from it. And I think with a few close friends and colleagues, we try to do this for our main field of work, which is bariatric surgery. And why this article was recently published in Obesity Surgery. And why are we talking about this is we all know these things will happen, and I'm sure we are all smart enough to learn from our mistakes. But I think the key thing, as said by somebody, is to learn from somebody else's mistakes. So how did this start? They started just to introduce what we have within the NHS, as we have a lot of international attendees here. We have something called as a national reporting learning system in the NHS. Hereby, anybody, any staff, be a surgeon, staff nurse, healthcare assistant, can report a critical incident that they feel may have compromised the patient care, safety, and may have potentially caused harm. This is done in a confidential manner by submitting all the information online. Now, these incidents are then critically reviewed, and when they come to think that, okay, this might have caused severe harm, then they could escalate to becoming a patient safety alert. And at that time, then these are widely shared by the central body throughout the NHS, which has hundreds of hospitals, as well as in the private sector. The problem is, if the incident does not escalate to a safety alert, we think there is very limited exchange of information, and this is where we thought we could look at the incidents and probably learn. And we looked at bariatric surgery, and I think unsurprisingly, there were very few reports on patient safety in bariatric surgery, and the handful of ones that we found were mostly related to malpractice claims against surgeons or bariatric team. We all know that the number of bariatric surgery procedures is increasing, and we're all proud that we have raised the safety profile of bariatric surgery. We have favorable clinical outcomes. In the UK, we do just under 10,000 procedures annually, and as we are all aware, hundreds and thousands are done internationally. So with this study, we aim to examine the NRLS database, and we specifically aim to look at bariatric surgery-related reports. We try to identify some learning themes and outcomes from the study. So what did we do? We retrospectively analyzed the NRLS database, and we had exclusive access to this national database, and it is from one of the biggest healthcare organizations in the world, the NHS. And we looked at over 15 years period from 1st April 2005 to 31st October 2020. The database gives us limited information. So we used several different keywords to cover different bariatric surgery, metabolic surgery, different procedures, and see what we got as a result. And then we tried to, the incidents we got, we graded them into severity based on our own clinical experience. So if something that would have caused mortality or significant risk of reintervention or readmission, or caused a protracted length of stay, we graded that incident as severe or leading to a severity score. The medium was anything in between, sort of, which did not meet the criteria of severe, but did alter the post-operative usual pathway. And anything below this was graded as low, where we thought there is a degree of potential harm, but it did not happen on this occasion. And then we also tried to categorize the incident based on which part of the patient care could be improved or could be held not in a way responsible, but could be improvised to prevent such things. So if there was anything with equipment failure or infrastructure or staffing issues, we graded those together in one category. Any errors with medication prescribing or administration were grouped as one. Anything to deal with communication or documentation was put together as one. And other category was related to clinical errors or technical issues, or where there were clear breach of protocol. Any incidents that did not sort of fit into any of these categories were graded as miscellaneous. So coming to the results, what did we find? We found 1,266 overall incidents. And as I said before, we had very limited information on a lot of them, but some we could not understand what was a clear learning point, and we could not analyze them further. And hence we had to leave them out. The ones that could identify a clear learning point were 541. And then we sort of divided into preoperative, intraoperative, and post-operative to sort of mimic the patient's journey. And majority fell in the intraoperative category, which were overall 206 incidents and making up just over 38%. The preoperative incidents were 164, about 30%, and post-operative were 171, which is just over 31%. And if you look at severity, majority of the incidents were graded as medium severity, and there were 244 incidents there, and about 45% of the incidents. Unfortunately, about 150 fell into the high severity group, and which makes it 27%. And thankfully, about 147 were low severity, about 27% of the overall incidents. So if you look at the preoperative theme, we had 164 incidents in it, and we could divide them into 15 different themes. It's difficult for me to go into all the detail that we have published, but I'll try and pick up the salient points. So amongst the high severity ones, there were 50 of them, and all of them were related to some kind of error or mismanagement of the venous thromboembolism prophylaxis. Whether the dose was incorrect or the duration was incorrect, but that was a problem. Now, what we have done is we had no recommendations from the NRLS database. So amongst the 5 authors who are all consultant surgeons in different units within the UK, we have tried to come up with some kind of recommendations. And here, I think we all agree that we should have a very clear protocol for venous thromboembolism prophylaxis for these patients, whatever suits for the individual unit and hospital, but it should be a very clear protocol. One thing that we've highly recommended is having a bariatric pharmacist from the start. It does help to plan the perioperative lot of medications, as will come through, but especially the venous thromboembolism prophylaxis. If you look at again at the incidents that were in medium severity category, again, they were mainly related to medication errors, whether it was in prescribing the patient's routine medications or perioperative insulin or anticoagulation or antiplatelet management. Again, I cannot emphasize more to have a pharmacist dedicated to bariatric surgery being involved right from the start. Thankfully, majority of the preoperative ones were of low severity, and a lot of them were related to infrastructure, such as HDU bed not being available, patient was listed for wrong procedure, I think mainly sort of miscommunication, or sometimes for a very high risk category patients, such as patients with chronic kidney disease, type 4, 5, there was no clear plan. And we have made some recommendations. For example, I think, the units who are now well established would agree that a majority of the bariatric surgical patients, they do not go to HDU. They do not need a high dependency bed. And with proper planning, staff training, the need for a higher level of care can be reduced. For wrong procedure, I think it's important that we have an MDT approach and senior surgeon consultants are involved. And to avoid any miscommunication, maybe have a electronic submission of forms or waiting list forms. I'll move on to the intraoperative category, and majority of the incidents were in the intraoperative category, about 206, and we could categorize them further into 27 themes. About a quarter of them, so 53 in total, a number were unfortunately high severity. And one of the one which can be quite stressful when you're operating is involving a tube within the stomach in the stapler. Now that could be an orogastric tube or sometimes a nasogastric tube or a temperature probe. Here, I think the key thing is, first of all, very rarely we need nasogastric tube or a temperature probe for bariatric patients. Orogastric tube is used by most surgeons, and communication is the key with the anesthetist, especially if you're operating with somebody who you normally don't work with. And it's important that they can also watch the screen when they are making any kind of maneuver to the tube, done under vision. And if there is any problem identified, they have to communicate with the surgeon rather than continue to push. Otherwise, it could also lead to, if you see further down, there have been reports of esophageal injury with orogastric tube. So it's down to communication and working as a team in theater. Secondly, there were these were the majority. I think about 17 incidents of these were reported. Then there were incidents like lost needle, about five of them. This can happen with any procedure, but with bariatric patients, it is very difficult to find the needle, even if we do an X-ray on them after that. And these are small needles used in laparoscopic surgery, can easily be lost. So care should be implemented. We've got to introduce them under vision, remove them under vision, and try and avoid withdrawing the needle from a 5-millimeter port. There have been instances of when a gastric band has been removed, and it looked at, once it was removed, there were missing parts of gastric band. There were incidences of broken instruments, like such as graspers, most commonly. And the advice here is that if we are using, if we will use these instruments, but they at the earliest signs of wear and tear, it's important to replace them. There can be a lot of torque doing bariatric surgery, and using worn out instruments can be dangerous. The further down below are thankfully very rare, things like specimens not being removed, like resected gastrojejunal anastomosis or parts of a sleeve stomach, and even a lost tonsil swab. I think this is down to communication again within theater with the scrub nurse, and any specimen that we're planning to remove should be included in the count. I think these things will not happen in open era because we remove the specimen straight away as soon as it is resected. But in laparoscopic surgery, we leave it till the end of the case, and hence these things can happen. Thankfully, these are isolated occurrences. Continuing with the intraoperative theme, the majority thankfully fell in the medium severity, and about 3/4, about 153, were in this category. Majority of them were because of unavailability or faulty equipment. So like graspers, ultrasonic shears, sometimes the operating table was not the right one for a bariatric patient. Again, down to infrastructure planning and making the right equipment available. A few incidences have been of patient slippage from the bariatric table. If not the whole patient, then some parts of the arm of the patient or the leg of the patient, which is only revealed later in the form of peroneal nerve palsy. Now, this can be hugely distressing to the patient and the whole team. The idea is, what we recommend is that the patient is positioned in presence of a bariatric surgeon, and before we start, we should be happy with the position and that the patient is nicely strapped to the table. Also important to make sure that the bony prominences are nicely covered and are not against any part of the table that can cause compression nerve injury. Then there were some, again, not many, I think these are about 5 or 6, where the intraoperative decision was to change the bariatric procedure or no procedure was performed. Now, this can happen. However, it is all down to communication and consent. Proper consent is important. It is rare, but it is not uncommon to be involved where plan was to do gastric bypass and it had to be converted to a sleeve gastrectomy, or sometimes no procedure was performed. This could be because of adhesions or because of the state of the liver. But I think if it's consent, patient is consented accordingly and well informed, it should cause less stress to the whole team and more importantly the patient. Stapler malfunction has been reported. Again, I think it's mainly down to staff training. The scrub nurse who's handling you the stapler should know which stapler is required by the surgeon. I think it can still happen. At the end of the day, it's a device. I think if it happens, our recommendation is probably get a colleague involved and see what their suggestion would be. Often this you may have to use another stapler, or very rarely you may have to undo the stapler and sometimes suture, but can be quite stressful overall. A couple of reports have been about incorrect part of small bowel anastomose. Again, we can see how this can happen, but it's all down to staff training, especially when we have new members of the operating team commencing. So I think I'm running slightly behind, so I'll move on further. If you look at the post-operative theme, thankfully, not many high severity, about 47, and they were mainly down to inappropriate diabetes control in the post-operative period. There have been few instances of delayed diagnosis of an internal hernia or a slipped gastric band that have led to gastric necrosis. Few incidences of, again, in the post-operative period, of wrong medication being prescribed. And as I mentioned before, would reiterate again, involving the pharmacy, multidisciplinary approach, sometimes involving diabetologists, hematologists, is crucial to avoid such errors. Majority were thankfully of low severity where the protocol was breached, so patient was given oral intake that was not appropriate or dietetic cover was not available. So based on this, overall, if I can summarize what we have done as the authors, we have suggested a proposed checklist. We have put this into action at our center, and this can be modified. All we have done is, based on the recommendations that I have been throughout the presentation, we have put them together as a checklist, and this can be used by relatively young bariatric units to then modify as per their local needs. Our study did have some limitations. As I said, the first and foremost is that we did not have all the information, and we have used our own clinical judgment to sometimes learn a learning point from these incidents and also come up with some proposed solutions. So clearly these are not being approved by a an academic body. But the thing is, all the 5 surgeons were operating in different units, so there is some kind of justification for our proposed solution. There has been underreporting. I think the numbers are indicative. I'm fairly certain a lot of incidents are not reported. or sometimes even over-reported. So that can be an issue. Having said that, I think this is the first of its kind, and as I said, it's published in a peer-reviewed, the foremost journal in the world of bariatric surgery, obesity surgery, and hopefully the proposed checklist would be useful to new starters. And I would like to thank the whole team who was behind this study. A lot of them are faculty on this meeting, and also to the NRLS database who gave us exclusive rights to look at their database. And thank you so much.
Thank you very much, Bridge. Wow, that is quite a lot of work in there. And I should accept that this so-called NRLS database, I didn't know that it existed, but the whole amount of work and the data you presented is, what shall I say, it's telling, humbling, a bit embarrassing, but we could all see ourselves in all these situations, and starting from VTE prophylaxis to drug errors, great amount of work. One thing I just wanted to comment on your last slide, wouldn't it be great to get this across your checklist into a wider platform, as you'd suggested? Have you done anything about it into bigger societies or something like that?
So, Balaji, thank you so much for first of all, I think I agreed it was a mammoth effect, but it was all teamwork. And I think my dear friend Chetan Parmar presented at BOMS, and we are trying to, it is being talked about with the, it's a wider team. So we have to speak with all the MDT members, and I'm sure we can all learn from each other, and that's the whole idea. So yes, we are trying to create awareness, and this is probably the first step. So more to come, hopefully.
Well done, and thank you.
Thank you.
Thank you very much, Bridge, for that excellent presentation. I would also like to thank Sanjay and Chetan for the invite and brilliant conference. Thank you so much. Without much ado, I'd like to introduce Professor Jane Blaisby. Jane is a professor of surgery at the University of Bristol. She directs the Bristol Centre of Surgical Research. She is the chief investigator of NIHR HGA band sleeve study. She also supports numerous other surgical trials, including Romeo and Sunflower, as she believes that designing and delivering large multi-center randomized trials is an important way of changing practice. Jane is today going to talk to us about why randomized surgical trials are relevant to clinical practice. Thank you, Jane.
Thank you very much, and hopefully you can hear me. Good afternoon, everyone. Thank you for this opportunity to present to you. So, randomized trials and how they can be relevant to clinical practice. I'm going to discuss those issues and put them in the context of the bi-band sleeve randomized trial. So we all know, don't we, that randomized trials are the gold standard. They're at the top of the pyramid of the evidence base. They're the gold standard for comparing healthcare interventions, the gold standard method. We all know that. We're very familiar with this triangle and the fact that RCTs are at the top, and then systematic reviews and meta-analysis of randomized controlled trials. And that's fine. I think we accept that. But the question is for you, and I wish we were all together to really discuss this, but the question really is, do randomized trials, surgical trials, make a difference to clinical practice? And do they influence what we do? I would say that at the moment in bariatric surgery, I mean, it will vary slightly across specialties, but in bariatric surgery, I would say that the answer to that is no, they don't make much difference. And I'm going to explain why I think that is and think about how we can work together to change that. The reasons why I think surgical bariatric trials do not really make much difference for what we actually do is that new procedures are introduced, new bariatric surgical procedures are introduced, and they become widespread without trials, very few trials all the time. Surgeons do choose to do what they want and they carry on doing that. There's variation in practice. We select different patients for different procedures for our own individual reasons, but there is no sort of shared agreement in many ways. And also, very few bariatric surgeons have actually had personal experience of randomizing a patient into a trial. It's not part of our culture to work together on randomized trials. You know, completely different to other specialties in oncology, for example, or in even respiratory research now with COVID trials. You know, we in the UK, we just ran trials to get answers to questions. You know, in surgery, especially in bariatrics, there's not many randomized surgical trials that are conducted. But what we need are trials that are designed and conducted that are relevant to practice. And that's one of the key things, because not all trials actually can make a difference. And that's what I want to step through now, because the type of trials that are needed are pragmatic in design. And this is a really key issue. What is a pragmatic randomized trial, and why is a pragmatic trial relevant to clinical practice? Because pragmatic trials have quite distinct features that I'm not sure everyone's particularly aware of. So I'm just going to step through the difference between pragmatic trials and what you might call the opposite of that, an explanatory trial. So typically, an explanatory surgical trial is small in numbers. It's usually single center, comes from one expert center. The patients are highly selected, as opposed to a pragmatic trial, which is multiple centers, multiple surgeons, few patients are excluded. The outcomes in an explanatory trial are typically short-term, maybe physiological outcomes, maybe surrogate measures, as opposed to pragmatic ones where you're talking about, can you measure long-term patient benefit? What's the actual long-term benefit about this intervention? So for example, in a trial of minimal access versus open surgery, for example, explanatory trials might measure blood loss, might measure operating time, those sort of things. They're of interest, but do they translate to patient benefit? And in a patient benefit trial, in a pragmatic trial, you'd measure that in terms of recovery, perhaps long-term quality of life. So do those early differences translate to experienced patient benefit? And another key difference in a pragmatic versus an explanatory trial is the nature of the surgical intervention. So an explanatory trial will have a tightly controlled intervention delivered by a few experts, maybe in the way that they think it's best to be done. Whereas in a pragmatic trial, you have lots of surgeons, slightly messy, we'll come on to how messy biband sleeve is in a moment, and a range of skills, because that's the nature of surgery. But you're really evaluating a whole intervention and its accompanying interventions versus another to see if it makes a difference. So those are the key features between the two types of trials. There they are there. And the question is, what do we already know in bariatric surgical trials, you know, about centre surgeons' outcomes in the RCTs that exist? And, you know, what is the existing evidence? We've kept an updated systematic review alongside the biband sleeve study. And over the last 8 years, there are 15 randomized trials we've been able to identify. And just summarised briefly here, by far the majority compare bypass with sleeve. And the primary outcomes look at different things, but importantly, some look at less pragmatic outcomes, such as gut hormones or bone density. Others look at more pragmatic outcomes, such as weight loss. You could say that's definitely a patient-centered outcome, quality of life. The timing of the primary outcomes are often only a year. Some of them do go up to 5 years, but a lot of them are fairly short-term. We all know that sustained long-term outcomes are what matter. But the thing that worries me most of all about the evidence base for bariatric surgery is that next column, and this really worries me. If you look at it, nearly all of them are single-centre studies, apart from three. And you know that a single-centre randomised trial cannot per se provide evidence that's generalisable. The sample sizes are also fairly small. In total, in the world, think of all the bariatric procedures that undergo, but the total number of patients randomised is just over 1,400 patients. You know, this data is difficult to say are generalisable. And that's what we decided to address. So nearly 10 years ago now, we sat down and designed what was originally the biband trial. And then we adapted it to become Bible and sleeve and have 3 groups. And we purposefully designed this trial to be pragmatic, so that the results will be generalizable, at the very least to the UK. I mean, I would like to think they'll be generalizable further afield, but they're absolutely generalizable to the UK. And I'll explain to you why as we go through. So in 2013, we had this 2-group trial, and we wanted the inclusion criteria to be wide, and we were aiming for, of all patients coming to bariatric surgical units, for 60% of them to be eligible to the trial. 60% is, you know, more than half of patients to be eligible, so the results would apply to most patients. The primary endpoint is at 3 years post-randomization, so it's a sort of moderate term. In the perfect world, you want a 5 or 10-year endpoint, but it's so difficult following up patients, so we've gone for 3 years, a combination of weight loss, of course, and a patient-centered outcome, an additional one of quality of life, patient-reported quality of life. Now, the interventions in BBS, as we call it now, in Bible and sleeve, are standardized in that the centers have to have a certain amount of expertise, a minimum of 2 participating surgeons per center, but most of them had a lot more than that. And the surgeons themselves needed to have undertaken a good number, but they weren't all necessarily experts. And we monitored key components of the interventions to keep it safe and to a standard, but we weren't strictly controlling them. And we started off by band in just 2 centres to test whether we could recruit. As some of you will know this, because everyone said back then it would be impossible to do this trial. And so I really take my hat off to these guys here who look very young, these photos from a while ago, but they did it. They had a go at recruiting and we trained them. And initially, you can see that the first 3 months, they really struggled, but some training was provided because we audio recorded the consultations. We taught them how to balance the information about the procedures and explain clinical equipoise. And in the pilot study, they learned how to recruit. They learned how to give informed patient consent, not giving their own personal biases, but to explain what was known about the procedures. And after the pilot study, we demonstrated that a bariatric randomized surgical trial was possible. We then got the green light to go ahead and expand it. And at that point, sleeve gastrectomy was added to the trial. It was adapted to become 3 groups. And we extended it to a multi-center study, 12 centers, 52 surgeons. That's a good number of surgeons and a good number of centers. And this is what most of all makes it pragmatic in design. I really am grateful to all the teams involved in this study. It's been a 10-year piece of work, and whilst there are some surgeons and nurses shown there, there are loads more involved. But a big thank you to everyone, including Sanjay. There he is in the middle. So we were aiming for 1,341 patients. This is how we got on. So we initially screened all the referrals being referred to those hospitals, and that is nearly 7,000 patients were screened for eligibility. And as I said, we wanted 60% to be eligible. And in fact, at the end of the trial, we had 68% of patients eligible. So it's absolutely pragmatic with wide inclusion criteria. And of those, we managed to consent and randomize a third of them. That's over, 1,300, just over 1,300 patients. A third of those patients accepted randomization. That is amazing. This will double the world literature on randomized evidence for bariatric surgery. It's a very important pragmatic study. And you can see the lists of the centers taking part there. We've completed recruitment. We've randomized all these patients, and we're now in follow-up because this recruitment was completed in 2019. 3-year follow-up will be completed on everyone by the end of next year. An exciting time that will be. How many have we managed to operate on? Well, thank goodness the pandemic didn't come till 2019, was it 2020? Because the majority of our patients had undergone surgery. Some have withdrawn, 41 are waiting around because of the pandemic, and some have crossed over. Now that's typical of a pragmatic surgical trial, that you may get 10% withdraw, you may get 9 or 10% who cross over, But in amongst the total number of nearly 1,400 patients, that's fine. It just means that the confidence intervals of the results will be slightly wider than we would have wanted them to be. We're still going to get good comparative data. I think the crossovers are really interesting, that these 107 patients, really interesting why patients did not accept their randomized allocation. 72 of them crossed over because of patient reasons. Might mean we didn't randomize them carefully enough, but you'll see that not everyone went from bypass to banned. There were crossovers in all directions. And there were clinical reasons for crossovers too. Some occurred preoperatively. Those could have been avoided to have been more careful at the point of recruitment. The perioperative reasons for a crossover shown you there can never be detected preoperatively, and that'll always happen. But we're comfortable that 9% represents, it's still high scientific quality. Our co-primary endpoint of weight loss and quality of life, as I say, is measured 3 years post-randomization. And we've been struggling to get all this data in the pandemic, and also just because it's difficult to follow up patients post-bariatric surgery. But shown here by centre, you can see we have 86% of patients with weight data at 36 months and 81% with quality of life data. This is good. We estimated our sample size on the basis that we had at least 85% with follow-up. We inflated the sample size to make sure we had those numbers. So provided we can maintain those figures, then things are looking as if the data from this trial will be reliable. How pragmatic is it? Well, I think I've already shown you, I think it's pretty pragmatic. I think we give ourselves a tick for its setting, lots of centres, lots of surgeons, few exclusions, patient-centred long-term outcome, interventions that are applied flexibly by multiple different surgeons. So we think that, will the results of buy-band sleeve influence clinical practice? Now, some of the surgeons in our trial think they won't, which they could well be right. But the results will be generalisable in the UK. They'll absolutely influence all future systematic reviews and meta-analysis. They'll provide the biggest box in those plots, whisker plots, to influence the final information. In terms of international practice, if the country has a healthcare system that has guidance, evidence-based guidance, such as we do in the UK with NICE, this study will influence that. But perhaps most importantly, we will have prospective comparative data on lots of different things, lots of different comorbidities and aspects of quality of life that will be able to, for us to communicate with patients about the relative impacts of the 3 procedures, so they can choose which ones they would want to undergo with actually comparative high quality data. Perhaps the most important thing about buy-band sleeve, and of course it depends on the results as well. I mean, you know, if the results show something shocking, goodness knows what it'll do to clinical practice. But the other thing is, and this is really important to me, the results of buy-band sleeve will, and the fact that buy-band sleeve has happened, will really influence research, bariatric research in the future. It will influence future trials. We have shown that we can work together to deliver these big trials. We have shown we can deliver protocols across 12 centres. We have shown we can follow up patients effectively. And that's difficult. Collaborating with people over a long period of time is just difficult because we're human beings. But if we can do it, we can answer important future questions. In future, we can make trials more efficient and faster. And, you know, we really do think that this is the way forward in order to get evidence-based practice. So a big thank you to everyone involved, and pleased to take any questions.
Thank you so much, Jane, for the lovely presentation. Remarkable feat to get all those surgeons together to cooperate and to, you know, relay a sense of equipoise to our patients and remove our biases. Susan, why do you think, you know, that it's difficult to do RCTs in obesity surgery? I mean, is it that, you know, say if you were doing the study now, would it be a mini buy-band sleeve or something like that? Is the specialty evolving, you know, a bit too quickly, like, you know, an RCT giving us sort of old results, you know, that maybe at this point might not be, you know, sort of what we're doing. We know that right now the mini gastric bypass is the third most performed operation. What are your feelings?
Well, I think you're saying what would be the next trial and how could we do it with mini bypass? I think that's what you're saying. It's a bit difficult to hear. What we would suggest is that the winner of bi-band sleeve, which we'll know next year, is compared with mini bypass in a randomized trial, because in a pragmatic design, because that's needed, I think. And we think we could do that quickly and efficiently, because we've all learned how to work together. We've learned how to randomize, and we've also learned how to collect data, and we would go for much less data and be more efficient about it. And because it's such a common operation, we actually think we could answer that in 2 or 3 years. But we know that our funding bodies won't fund such a trial until we've analysed the data of bi-band sleeve.
Thank you so much, Jane. I'll leave it to Balaji to introduce Prof. Shikora now.
Thank you very much. It gives me great pleasure and privilege to introduce Professor Shikora, who is very well known in the circles of bariatric and academic surgery. Professor Shikora is a professor of surgery at Harvard. He is the head of metabolic and bariatric surgery at the Brigham Women's Hospital. He has been the president of ASMBS in the past and is the president-elect of IFSO. It gives me great pleasure to introduce you once again, and off to you, Dr. Shikora. Thank you very much.
Thank you very much. Greetings from the Boston area, everybody. I've logged in early this morning, and this has been just a marvelous meeting, and I want to thank Sanjay and whoever else was involved with inviting me. And I want to get my presentation. Sorry about that. I had it all lined up.
Great picture of London.
Okay. So I was asked to speak about conceptualization to publication in bariatric surgery. And I am the editor-in-chief of Obesity Surgery for the past several years, so hopefully I could provide some tips that may make it easier, particularly for the young investigator, to have better results with getting their papers published. These are my disclosures, and obviously I am the editor-in-chief of Obesity Surgery, so I may have a bias or two. Anyway, there are many reasons why it's important, particularly in academia, to publish. And number one, it's an important vehicle for dispersing medical knowledge from one group to the next, from one country to the next. And like the study you just heard about, the results of that study may have wide impact. But it's also important for one's own career. They used to say publish or perish. So if you want to move up academically, you have to build a CV full of publications. Now, what all of us learn the hard way is not all submitted manuscripts get published, and in some cases, only a small fraction of it. So hopefully this talk may improve the odds a bit, particularly once again for the younger investigators. Now, if you look at this, this is data from Obesity Surgery, and what you could see is from 2011, 10-year period to 2020, the number of manuscripts submitted for consideration of publication tripled. So we have a lot of papers coming through. And what that does is it gives us the opportunity to be a bit more selective in what we accept. So we won't accept mediocre papers anymore. We don't need to. We only accept those papers that are truly worthy of publication. And in the case of obesity surgery, it was 49% in 2020. So half the papers that come in are going to be rejected. Now, let's talk about what journals are looking for. It's no different than a magazine or a newspaper. We're looking for fresh, we're looking for new, we're looking for unique material that's going to be of interest to the readership of our journal. So it has to be something appropriate for bariatric clinicians. The studies that are important, such as your current study, and that will add to the published literature, would be something that we would really like to see in our journal. Articles that are relevant to the field. So we're not likely to publish a paper on, let's say, uterine changes related to obesity, or something that was done in a group of rats that isolated some protein that may be related to obesity. That's not of interest to our readership. Our readership wants to know about limb lengths and pouch sizes and nutritional issues. The study has to be well organized and well written with good, proper English. And I can't tell you how many papers I send back because of poor grammar or because of poor organization, that they're hard to understand. And journals will have a number of article types to choose from. So you have to line up your article with one of the types. The most common is original contributions, which is basically a lot of the studies that you see in the journal, the clinical, and in some cases, a few basic science. Review articles, which is a nice overview of a topic. And that's gold for a journal, those two types of articles, because they have a very good impact factor, and that's how journals are judged, by their impact factor. But there are other classifications. Let's say you wanted to put out an early release of some of the data from your study. Well, that may be a new concept. Or if you developed a very nice trick for preventing losing a piece of equipment in the abdomen, that could be new concepts. We do publish these other types, but once again, our money is on the original contributions and the review articles. We do not accept case reports because they have no beneficial impact when it comes to the impact factor. So, before we say another word, I have to stress this point, is that you must see what the journal wants of you in how you write the paper. And it's called Instructions for Authors. It will be different, or could be different, from one journal to the next. It could be a cumbersome process, but you must follow it, because if you don't put the paper together the way the instructions of the journal ask for, the paper is going to be rejected, even if it's high quality science. And what you see here on the left side is the different categories of the components of a good paper. And once again, this will vary from journal to journal to journal. The abstract, keywords, teaching points, and we'll talk more about that in a moment. What you see over here is relatively new, and that's what's called a graphic or visual abstract, which we've added, and a lot of other journals have added to the manuscript because they're easy to read and they're easy to get the gist of what's going on without reading through a lot of the wording of the other parts of the journal. So this is a nice thing, and it's been added so you can expect to have to fill that out as well. Now, let's talk about the components. The abstract is the most important part of the paper in my view, because that gets it to the next level or not. We get over 100 submissions monthly. I go through every single one quickly, look it over, and then decide whether to send it to an editor or to reject it. And it's on the strength of the abstract. Consider it the headlines of the newspaper. When you read the headlines, it's written in such a way to catch your attention so you'll read the article. If not, you may find it not worthy of reading and you skip by it. The abstract needs to be well written. You need to wordsmith it, succinct and organized, and again, following whatever requirements of the abstract are demanded of you from the journal. And I like to ask the following questions. Is it written in good English? Does the abstract appear sound? Does the data look sound? Is it appropriate for our readership? And does the data support the conclusion? And surprisingly, in some cases, it does not. Now, we ask for a structured abstract, which means it's smaller, it's only 250 words, so you really have to wordsmith it. It needs to be right to the point, right on focus. it has to have the following subcategories: the background, which is just why you're doing the trial or the study, the methods, how are you doing it, the results, and a little bit of a conclusion that you actually supported your hypothesis with your data or you didn't support it, etc. How about the introduction? Well, now that I caught your attention with my abstract, I have my introduction for you to read, and that too needs to be well written. You have to be careful what you say. You want to say it just right because you want to keep it brief. You're explaining why did you do this study? Why? What prompted you? What's your hypothesis? And it can include results from similar trials to support what you're doing, or to actually say that what you're doing is going to be, your hypothesis is opposite of what that past presentation suggested. And it shouldn't be very lengthy because, once again, the reader won't read it if it's long and boring. How about the methods? Well, the bottom line is that you need to describe what you did well enough that somebody else can pick up your paper, follow your methods, and get results similar to what you did so that it's reproducible. And that's very, very important, but you don't have to all-inclusive on your methods. You need to explain it enough for somebody else to follow what you did. And you need to have sufficient patient follow-up and sufficient power. If you're looking at randomizing 12 patients versus 10 patients, there may not be enough power there to prove anything. How about the results section? Well, the results section is where you clearly state what you found. You found that your hypothesis, for instance, for example, was that sleeve gastrectomy was just as effective as gastric bypass for diabetes control. You studied it, and you found that was exactly the case. So that's the starting part of your results section, is we demonstrated that the sleeve gastrectomy was just as effective for diabetes as the gastric bypass was. Or maybe you found the opposite. It was not as effective. You don't interpret why in this section. This is only to say what you found. Your interpretation will come in your discussion. So hold the fort on that. The other thing is that tables, graphs, figures should highlight or help you present the data in an organized fashion. It shouldn't overwhelm you with many, many complicated tables and graphs, or what's in the tables and graphs are also in the results section, just written in longhand. You're just duplicating the same thing. So it should augment what you're doing, not duplicate. And here we get to the last major step, which is the discussion. And once again, you should state whether or not the hypothesis was verified. You should talk about in the context of other studies, that a study by Shikora found opposite results. Here's why we think their results were opposite ours. Or the study by Dr. Jones demonstrated similarities to what we found, and the reason for that is the following. You need to explain from the literature a little bit of what's out there with the topic that you were studying. However, you don't need to write a huge textbook. You need to just have, once again, a relatively succinct and organized review of the current literature. Short and sweet. Now, as far as references, you don't need a zillion references, but you do need to reference every major scientific point that you cite, because it had to come from somewhere else and it needs to be recognized. It's best to do the most up-to-date references, but it could be an old reference because that old reference is important. For instance, it could be Walter Pori's paper from 1985 about diabetes and gastric bypass. So use your references to support the points you're making, but don't overwhelm us with 200 references, for instance. Now, what about ethics? Just like doing a study, you have to show high ethical behavior. You have to do the same thing with your publication as well. And I have to tell you that it's almost a yearly basis that we're uncovering some unethical behavior. We had it this morning in one of your earlier sessions. Yeah, almost done. Where one of the papers cited was a paper that was pulled from publication because of the data. So just to finish up, steps to publication: develop a good research question, research the topic, do your homework, make sure that it hasn't been written about 100 times already, write a good manuscript, submit the manuscript to the journal once it's properly written and following the instructions. And when it comes to the journal, then we first look at the abstract. We determine whether it's worthy of moving on and being looked at by the editors, or whether the actual paper is not appropriate for our journal and we will reject it. Those that get through to the editor will then come back to the authors, maybe for some revisions, etc. And the grounds for rejections are basically very straightforward. Not a good paper. The paper was poorly written, the material was not of any value to us, it was disorganized, the grammar was poor. Tips for improving success: create a good research project, do your homework on it, make sure that you're not repeating the work of others, you're adding to it, make sure you write a good draft. And I believe having a mentor, somebody who's been down that road, has published before, who can look your paper over or join your project and help you go through the steps because they've done it before, is appropriate. And choose the appropriate journal. Don't send a research paper to a surgical journal, for instance, an animal research paper, and format the paper according to what the journal asks for in its instructions. What to do if the paper is rejected? First of all, don't blame the reviewers. They're doing their job, and very often they're correct. Follow their instructions to rewrite or to add or to subtract according to their wishes. And in worst case scenario is send it to another journal and try again. So in conclusion, researching a topic and then writing a manuscript is a worthy endeavor. It may be difficult from time to time, but it could be extremely beneficial to one's career and to the field. Not all manuscripts are going to be accepted for publication, and all of us have had rejections, so it doesn't mean it's not a reflection upon your abilities. Follow the journal's instructions and try again. And with that, I would say thank you very much for letting me speak today.
Thank you very much, Prof. Shikora. That was a very concise and detailed back-end aspect of what is to be expected for a publication, and who more could deliver this apart from the chief editor of Obesity Surgery. So I'm consciously aware that we're running behind time, and the colleagues for the next session seem to have been logging in. So if Cynthia hasn't any questions, could we consider ending the session?
No, thank you, Prof, for the wonderful presentation. I mean, sometimes some of us see it from the other side. We're reviewing papers, we're submitting our own, and I think the advice that you said about mentor is really important. Thank you.
I think that's very helpful. And by the way, I've had papers rejected from obesity surgery as well. So it's really a good system that we have in place.
Thank you.
Thanks.
Over to the coordinators.
Thank you. Thank you very much, everyone. Cynthia, Balaji, Scott, Bridge, Jane, I think she had to leave. That was an excellent session. I know we are running late, I think. So thank you. I think we'll conclude this session.